Thank you, Miles. I was asked to give a little bit of an update on the work that we're doing in COVID surveillance in school kids. Next slide, please. Uh, as, as you now know, there's a lot of contention about the role of children in the COVID pandemic at the moment. What we saw during the first peak of the pandemic through PHE surveillance is that the cases in children increased from around the end of February, when some kids returning from the Italian ski resorts started getting the virus, and then peaked in the middle of April, same as adults, and then declined very rapidly after that by the end of April. And what we saw is that children of all ages were affected, but actually only 1% of all confirmed cases were in children at the time. And the vast majority of those children did not even require hospitalization. We only had about 1,500 cases during the whole first wave of the pandemic, and only 4 deaths, and 3 of them were in children who had severe neurodevelopmental problems. So children, we know, seem to be less likely to get severe COVID disease, but their role in infection and transmission is still not certain, to be honest, because we just don't know how important their contribution is to the current pandemic. Next slide, please. One of the big things that people were worried about is that as we came out of the first lockdown, we allowed primary schools and preschools to go back to schools, and a couple of secondary school year groups as well. And there was a concern that if children were able to transmit, especially if they were asymptomatic or only mildly asymptomatic, then what you're potentially doing is putting a whole bunch of children together into a room and potentially putting their family members at risk, because they could take the infection back home and even spread it to the community. And that was quite a big concern, because the vast majority of respiratory viruses that we know of tend to be transmitted through children. And therefore, we have so many children, childhood immunization programs to try and protect the population. Next slide, please. So what happened is that we were just doing our little study of 10 schools around London to try and understand the role of infection and transmission. But it soon became apparent that there wasn't much else going on around the country, and we needed to do a much larger scale study. So we were asked by the Department of Health to try and expand our study to across England, and we had literally 2 weeks to do it in. So from the 8th of June, we essentially, within 14 days, we managed to contact 192 schools around the country, and we recruited a total of 138 schools in the end. And we divided them into 2. We had 89 schools where they had weekly swabs for at least 4 weeks from the time they were recruited until the end of term. And then we had schools where we had blood sampling in children and in the staff members across 5 major sites. So that was London, so it's North London, East London, Oxford, Manchester, and Derby, with the red dots that you see on the map. We had 49 schools that took part in that initially. We recruited more than 12,000 staff and students over that time period. Next slide, please. And for the weekly swabs, we basically posted boxes of the swabs to the schools, and we identified a healthcare professional who could help take the swabs in the schools from the children, and the staff took their own swabs, and the samples were couriered to Colindale, where they were tested as quickly as we could, usually within 48 hours, and reported back if they were positive. For the blood schools, we had a team of clinicians and nurses and phlebotomists going into individual schools. We usually took up their assembly hall or the gymnasium, and we took the blood samples from the children and from the staff ourselves and brought them back to Colindale for testing. Next slide, please. So these are the summary of the results. As I said, in the end, we had 12,026 participants, and we had complete information from 131 schools. There were an average of 93 participants from the weekly swabbing schools and 43 participants from the blood schools for antibody testing. Around 60% were students and 40% were staff. We tested a total of 43,000 swabs. And interestingly, despite all the testing that we did, we only identified five positive swabs between June to middle of July. And 3 of them, who basically were staff members, were turned out to be false positive. They had a very high CT count on the PCR, means they had an extremely low viral load if it was even genuine. We tried to test them again, and it was negative. We also tested their antibody levels 4 weeks later, and we found that none of them had an antibody response to the virus, which is really unusual, but would suggest that they probably did not have a virus infection. So these we would have considered as false positive. So that left us with 2 staff members and 1 student who was positive during that period. And we could estimate a risk of SARS-CoV infection of 3.9 per 100,000 students per week and 11.3 per 100,000 staff per week. So you can see that staff were approximately 3 times more likely to be infected than students during that period. Next slide, please. Every time we had a positive swab, we had a list of actions that needed to be taken. So the results were reported every day, and 2 different independent persons checked the results to make sure we don't miss any positive samples. The positive results were flagged and actioned on that same day. We contacted the participant, and all the household members were asked to stay home. And notably, the family was recruited to another study, which is a household transmission study, which linked up with the school transmission study, where they had additional swabs and serologies done. A risk assessment was taken with the schools, and a decision was then made whether to exclude just the contact, just the bubble, the whole class, or the whole school, depending on the level of risk. Next slide, please. This is a summary of the 6 positive cases that we had. The ones in red are essentially the ones that we think are genuine infection. But you will notice that because we couldn't take a chance, all of them were actioned as if they were positive, and in 5 of them, the bubble was isolated, and 1 of them, the school was isolated. What you see over there are all the testings that were done. So not only did they have a positive throat swab that was repeated and found to be positive, they also had antibody levels done, and 2 out of the 3 that had an antibody test had a very good antibody response, and the 3 that were negative did not have any antibody response at the time. Next slide, please. So the other thing that we did, which was very unique and quite unusual, in that usually we do not go investigate in schools, and we definitely don't investigate with blood sampling in schools, and the vast majority of them actually did not have their parents there. They were chaperoned by their teachers who came in with them one by one, and they had a blood test by a pediatric specialist, either a nurse or a doctor. They had an anesthetic cream, local anesthetic cream, for half an hour to 45 minutes before the blood test was taken. And they essentially sat there without their parents, and they had their blood test done, and they ranged between 3 years of age and 19 years of age. So quite a broad range of children who took part in the study. Next slide, please. What we found was very interesting, and I think it's becoming very apparent with the emerging data, is that you see 3 bars for each of the sites that took part. The first bar is the students, and second bar is the staff, and the third bar is the community. And what you will notice is that there is very little difference in antibody positivity rates between the students and the staff compared to the community. So the 2 pieces of information that are critical of here is that students were as likely to be antibody positive as staff, and that both students and staff did not have a higher antibody positivity rate than the community, suggesting that this infection, that being in school did not increase their risk of infection and therefore being antibody positive. In fact, you will notice that in Derby and in East London, students had more antibodies than the staff or the community. Next slide, please. We did find some very significant associations with antibody positivity. In students, we found that non-white ethnicity being unwell with COVID and having a healthcare worker was a parent were all significantly associated with the child being positive for the antibody positive for SARS-CoV. We didn't find any association with age and sex or having a key worker parent. And importantly, attending school during lockdown was not associated with having a higher risk of antibodies or the frequency of attending school during lockdown for the students. Next slide, please. In staff, we saw similar associations as well. So being non-white, being unwell with COVID symptoms, and interestingly, even among the staff, having healthcare workers in the household significantly increase your risk of having an antibody positive outcome. The sex and having a key worker were not associated with having antibody positive. And again, attending school during lockdown, or the frequency of school attendance, or the amount of student contact that you had while in school during lockdown were not associated with antibody positivity among the staff. Next slide, please. We have continued the SCIDS family of studies. We have a study called SCIDS ILI at the moment, which is looking at influenza-like illnesses in children who are unable to go to school because they have a respiratory illnesses. They can go online and order a test for the whole family, and we will test them for COVID within 48 hours. And we will also test them for other respiratory viruses to try and understand what role they play in respiratory illnesses during the current academic year. Next slide, please. We have a SCIDS Plus study that we started in September. We have recruited 20 schools in 5 regions across England. We're recruiting a total of up to 6,000 participants, limiting 300 students and staff for each school. And we're going to do exactly the same thing again. We have tested them for their antibodies and for infection, and we will follow them up at the end of each term. If any of the positive cases are positive, if any of the cases are positive, they have to self-isolate, and the whole bubble is sent home. And we would recruit the families into what we call SCIDS Extra, where the whole family gets tested to try and understand whether the infection was coming from school or was coming from home. We are also planning a SCIDS Bubble, where we're going to test all the members in the family of the children who are sent home, of the staff and students who are sent home during, if there is a positive case in their bubble. Next slide, please. And finally, there's a large school infection study that is just about to kick off in collaboration with the ONS and London School of Hygiene that PHE is leading on. We're going to recruit 150 schools across England. We're going to recruit nearly 50,000 students and staff members. And uniquely, in addition to the nasal swabbing, we're going to start using oral fluid to test for antibodies at different parts of the academic year. The staff will be tested with a finger prick test, which is also unique and will give results very quickly. And the plan again is to try and recruit the family of positive cases into SCIDS Extra and the bubble testing to understand outbreaks in SCID bubbles. Next slide. So just to summarize, what we did find was that during the summer term between May and mid-July, we found very, very few infections in staff or students at the time. We tested a lot of participants in a lot of schools around the country, and we only found 3 positive cases. We found that antibody positivity rates were very similar in children and in adults, and we identified some risk factors for antibody positivities in the students and in the staff. Next slide, please. This is clearly not my work. There is a whole team of people behind me who've done a lot of hard work and had many sleepless nights to have all these different studies take off. And next slide. Thank you for your attention.
Great. Thank you very much indeed, Shamaz. A question that's come in is about our understanding of transmission in schools. I know it was early on, and also hopefully marrying that up with some knowledge that's coming out now. How would this impact on the strategy for vaccination, taking that we are going to get a licensed vaccine in the not too distant future? does it increase the priority to vaccinate children first to prevent transmission to the elderly, as you see with fluenza, or does it saying they're not such a great risk and therefore shouldn't be targeted first?
There's very little evidence for children being the primary source of transmission in this pandemic. Clearly, they do transmit and they do get infected, so we need to get that right. And the idea that children are less likely to be infected is getting weaker and weaker, because we can see very clearly that they develop very robust antibody responses. It's just that they are more likely to have very mild symptoms or no symptoms compared to adults. So they do get infected, and if they are infected, there will be a period when they can transmit, but that period appears to be very short. And it's possible that they may not be very good transmitters, because if you don't have symptoms, then you may not be as good a transmitter as somebody who's coughing and sneezing all the time. So the role of children in transmission appears to be very low. It seems like they have a very short period of transmission, and it looks like you need very close contact in a household type of setting contact for children to be able to transmit, rather than the open. Even the school setting would be a more open setting where the transmission between student to student appears to be very low. That's clearly very pertinent to preschool and primary schools. Secondary schools is a little bit different. They do appear to be more able to infect and transmit others. And we are seeing more outbreaks in secondary schools, but again, they don't tend to get very sick with their infection. The priority, therefore, must remain in the older adults and those with severe comorbidities. What children do is they disrupt the workforce, and so it is important that we also prioritize the critical workforce. That includes healthcare workers, that includes care workers, and other similar workers that are needed for the functioning of the country. And they would be the ones to prioritize for the vaccines.
Right. And then finally, someone's come in to say, and they may have missed it, they apologise, is an association between seropositivity and socio-economic deprivation?
That's a really good question. We haven't got that information for children. There's a lot of data from adults to show that. There are very few limited studies in children that are able to demonstrate that. But what you can clearly see that the major source of infection in children, even those going to school, is still a family member. And therefore, having a family member that is working in a high-risk area, which is typically healthcare settings or care homes, it's going to increase your risk. And obviously, the environment that you brought in makes a difference. So the number of people in the household is important, the size of the household is important, but we haven't gone down that route yet. But that is something that we can definitely look at.
Great. Okay, thank you very much indeed, Shamaz.